Hypothalamus and hypophysis, pituitary gland. A section of hypothalamus and hypophysis illustrates the neuronal, axonal, and vascular connections between the hypothalamus and hypophysis. Also illustrated are the major target cells, tissues, and organs of the hormones that are produced by both the anterior adenohypophysis and posterior neurohypophysis pituitary gland, sir. On the top left, they have highlighted the pituitary gland and zoomed in. They have labeled neurosecretory cells in the hypothalamus itself, neurosecretory cells in paraventricular nuclei, neurosecretory cells in supraoptic nuclei, optic chiasma, artery, primary capillary plexus, hypophyseal portal system. Then in the posterior pituitary, a vein. Anterior pituitary, they have highlighted secondary capillary plexus, vein, basophil, and acidophil. And under acidophils, they have labeled prolactin, which promotes milk secretion, growth hormone via somatomedins in the muscle causing hyperglycemia, in adipose tissue causing elevation of free fatty acids, and in bone causing growth. And then under basophils, they have labeled ACTH, which acts on adrenal cortex, TSH, which acts on thyroid, FSH and LH, which act on, they're shown acting on testis. FSH promotes spermatogenesis, LH for testosterone secretion, FSH for follicular development and estrogen secretion, LH for progesterone secretion, and finally in posterior pituitary, they have labeled oxytocin, which causes contraction of uterus, and also oxytocin causing mammary gland, what do you call, milk ejection, and ADH acting on the kidney causing water absorption, sir.
So figure 17.1, hypophysis, adenohypophysis and neurohypophysis, panoramic view, sagittal section, stain hematoxylin and eosin, low magnification. On left, there's connective tissue capsule, basophils, capillaries, acidophils, and pars distalis, sir, one half. And this side, infundibulum, pars tuberous, blood vessels, pars intermedia, colloid vesicles, connective tissue capsule, pars nervosa, sir.
Usually adenomas are arising from the anterior lobe. Can you all identify lot of blood vessels because they are the ducts? Whatever may be the organ, neuroendocrine cells will have a distinct cell border, and usually they are seen as clusters, and these clusters are surrounded by vascular structures. Usually the nuclei will be in the periphery, and some of them will have plasmacytoid appearance. They are not plasma cells, but plasmacytoid appearance. I am just drawing the nucleus just to show the plasmacytoid features. Sometimes they may be situated in the center also. And another characteristic feature, very fine chromatin distributed throughout the nuclei, very uniform chromatin, salt and pepper chromatin pattern. Reticulin stain, you can see in normal lobular pattern. This reticulin pattern is lost in pathological lesions of the pituitary. Reticulin stain, you have to remember for two important things. For follicular hyperplasia and follicular lymphoma, reticulin pattern will be lost. In any pituitary lesion, reticulin pattern will be lost. In addition to liver and sometimes even in kidneys.
Figure 17.2, hypophysis, section of pars distalis, pars intermedia and pars nervosa, stain hematoxylin and eosin, medium magnification. On top, it has been divided into three sections, pars distalis, pars intermedia and pars nervosa. To the left, sinusoidal capillaries, chromophobe cells, acidophils or alpha cells, basophils are called beta cells, nuclei of pituocytes, follicles, pars intermedia, cystic follicles, pars intermedia.
Can you see the colloid-like material in the pars intermedia? And you see these clusters. That's what I was telling you. And these are all separated by the sinusoidal blood vessels. And this is what will be highlighted in reticulin stain.
Figure 17.3, pars distalis of adenohypophysis, acidophils, basophils and chromophobes, stain azan, high magnification. To the left, basophils, acidophils, blood vessels, right, chromophobes, capillaries, connective tissue fibers.
And these are all Zellballen pattern. And that's why in paraganglioma or neuroendocrine tumors, you can see the Zellballen pattern. Now we are moving to thyroid.
Figure 17.2, thyroid gland, parathyroid gland and adrenal gland, the microscopic organization and general location in the body, of the thyroid, parathyroid, and adrenal glands are illustrated. Thyroid gland, follicle cavity, blood vessels, parathyroid gland, parathyroid capsule, chief cell, oxyphil cell, thyroid follicle filled with colloid, parafollicular cells, and follicular cells. Adrenal
Super.
gland,
Hmm.
capsule, zona glomerulosa, fasciculata, zona reticularis, medulla.
Thyroid gland, canine general view,
Hmm.
contain hematoxylin and eosin, low magnification. So parafollicular cells, follicle with colloid, follicular cells, follicle in the tangential section, connective tissue septa, arteriole, follicular cells, parafollicular cells, connective tissue septa, venule, interfollicular connective tissue, follicle with retracted colloid, capillaries.
There are few organs where normally they are ununiform, whereas in malignancy they will become uniform. Thyroid and prostate, please remember. And here you can see the follicles. They are of varying sizes and shapes. They are not uniform. Some of them are small, some of them are large. Okay, for example, this is a small one, large one, medium sized, small, large. So if you see follicles of uniform size shape distribution, then it will become follicular neoplasm. And there are some cells in between the follicles, they are known as parafollicular cells, and they are derived from C cells, and they give rise to medullary carcinoma thyroid, neuroendocrine, calcitonin, and medullary carcinoma of thyroid.
Thyroid gland follicles, follicular cells and parafollicular cells, sectional view, stain, hematoxylin, eosin and high magnification. Parafollicular cells, follicles with colloid, interfollicular connective tissue, capillaries, follicular cells, blood vessel, follicles in the tangential view, interfollicular connective tissue, follicle with colloid, parafollicular cells, follicular cells and retracted and distorted colloid.
Figure 17.A, thyroid and parathyroid glands, canine, sectional view, stain HNE, low magnification. First, we have the broad division, thyroid gland, connective tissue capsule, then the parathyroid gland. In the thyroid gland, we see follicles with colloid and follicular cells. Then, coming to connective tissue capsule, we see connective tissue trabeculae. And then in the parathyroid gland, we see chief or principal cells, blood vessels, capillaries, and oxyphil cells.
So you can see some clear cells which are known as chief cells. There are some cells with abundant granular eosinophilic cytoplasm, and they are known as oxyphil cells. And there will be a lot of adipose tissue in between normal parathyroid gland. That also you remember.
Figure 17.9, thyroid gland and parathyroid gland, stain HNE, 80 times magnification. On the left, we have thyroid, which has follicles with colloid and follicular cells. And then we have a connective tissue septum. And then we have parathyroid with chief cells and oxyphil cells. And they have also marked blood vessels.
Now this is adrenal.
Figure 17.10, cortex and medulla of adrenal, supraadrenal gland, stained with hematoxylin and eosin. On low magnification, we are seeing capsule, cortex, and medulla. In cortex, we are seeing blood vessels in connective tissues and trabeculae. And cortex is further divided into zona fasciculata, zona reticularis.
This is zona glomerulosa. This is zona fasciculata, and this is zona GFR, glomerulosa fasciculata reticularis. And then medulla. Very good.
We are seeing cells and capillaries, sir. In a fasciculata, we are seeing cells and capillaries. In each zone, we are seeing cells and capillaries, sir.
See, the zona fasciculata, does it resemble anything what we have already seen? Sometimes they resemble hepatocyte, like 2 or 3 cell cords. This is one sinusoid, this is one sinusoid, this may be 2 layers of hepatocytes. But what is the criteria will you follow? When do you call a liver? So, portal triad for liver, airways for lung. For each organ, you have to have criteria which should not be seen in any other organ. For example, central arteriole in spleen, Husserl's corpuscle in thymus. Like that, one major point you have to remember which should not be seen in other organ. Medullary cells will have that Zellballen pattern with a lot of capillaries. Okay, so that's why in the adrenal, the cortex and medulla is very, very important. Lesions of the cortical, mainly cortical adenoma and cortical adrenal cortical carcinoma. Lesions of the medulla வந்து pheochromocytoma.
Location of the testis and the accessory male reproductive organs with emphasis on the internal organization of the testis, the different phases of spermiogenesis, and the structure of a mature sperm. So the top here, there is a gross the mid-sagittal section showing the ureter, urinary bladder, ductus deferens, pubis, corpus cavernosum, penis, corpus spongiosum, urethra, prepuce, glans penis, then the testis, scrotum, bulb of penis, bulbourethral gland, anus, rectum, prostate gland, ejaculatory duct, seminal vesicle, and colon. Next, zooming in on the testis, they have labeled ductuli efferentes, ductus epididymis, ductus or vas deferens, and below the septum, then the testicular lobule, seminiferous tubules, tunica albuginea, and rete testis.
This picture is very, very important to know the gross pathology. We will see the important things. The ureter is coming here and it is opening into the bladder. And the bladder, through the urethra, they have not connected it. Through the urethra, it goes there. Okay, so that you have to understand. So we have 2 ureters and 1 urethra. Why it is important? In a cystectomy specimen, we have to have 3 margins, both ureter margins and the urethral margin. And then we have the prostate here, and behind the prostate we have the seminal vesicle. The seminal vesicle, they cannot remove by itself. When they remove the prostate, it will come along with that, and all the secretions are coming into the prostatic urethra. This is the prostatic urethra, and they come there along with the ejaculatory duct also. This one you can see testis, epididymis, and then vas deferens, and that comes there, and along with the seminal vesicles, they will go in there. And another important thing, the urethra is running in the corpus cavernosum. This anatomy is also very, very important in penile cancers. Whether usually it is arising from the skin or it is arising from the surface epithelium of the glans penis here. Whenever there is a cancer, we have to see, is it confined to the skin or is it invading into corpus spongiosum or corpus cavernosum. Have I told you urethra is running in corpus cavernosum? No, it is running in corpus spongiosum. Whether the penile cancer, is it involving the urethra, is it involving the corpus spongiosum and corpus cavernosum. This is the testis. In the testis, the thing you have to remember, it is full of seminiferous tubules. You see the seminiferous tubules, isn't it? So if you pull the seminiferous tubule, if you pull it with a forceps, it will come like a string. That is known as string sign, and as Abhijit correctly told, it tells it's a viable testis. And if it is a testicular tumor, string sign won't be positive. When it is positive, usually it is a non-neoplastic lesions. For prostate, you all know it is androgen derived tumor or androgen driven tumor. So that's why they remove the source of the androgen, and that's why they do the testicular removal in CA prostates.
Figure 18.1, peripheral section of testis, stain hematoxin and eosin, low magnification, tunica albuginea, tunica vasculosa, 3 is interstitial connective tissue, 4 is seminiferous tubules, 5 is interstitial cells of Leydig, 6 is seminiferal tubules, 7 is the septa, 8 is tunica vasculosa, 9 is seminiferous tubules, 10 is septa, 11 is interstitial cells of Leydig, 12 is interstitial connective tissue, 13 is blood vessels, 14 is germinal epithelium.
The cells you have to remember in testis, one is germ cells, the other one is Sertoli cells, the other one is Leydig cells. And germ cells, there is a lot of maturation related terminology. Primary spermatogonium, secondary spermatogonium, spermatids, and mature spermatocytes. They are all germ cells. And this germ cell and sertoli cell, they are located within the seminiferous tubule. Whereas Leydig cells is extra seminiferous tubule arrangement. Where is the Leydig cell? Interstitial cells here. And usually in a normal testis, these seminiferous tubules will be touching each other, and you see minimum connective tissue in between, like in the cortex of the kidney. Whereas as the aging process, for example, if you remove testis of around 70 or more than 70 years of age for see a prostate, seminiferous tubules will undergo atrophy if they will replaced by fibrosis. Okay, probably I should have drawn in red color, fibrosis. Or you can see eosinophilic membranous material totally replacing the seminiferous tubules. And in these cases, the Leydig cells will become more prominent because of the atrophy of the seminiferous. So we cannot call it true Leydig cell hyperplasia. It is pseudo Leydig cell hyperplasia because they looks like prominent because the seminiferous tubules are atrophic. Another structure you have to remember, these seminiferous tubules, they open up into sieve-like channels, like see here, how nicely one seminiferous tubule is opening into the sieve-like channels. These are nothing but rete testis. Rete means sieve-like. So they are the sieve-like structures, and they give rise to epididymis. The epididymis will arise from rete testis. So seminiferous tubules goes into rete testis, and rete testis goes into epididymis. And epididymis is equal to fallopian tube in females. Sometimes the germ cell tumors, if you see germ cell tumor, it can have germ cell intratubular neoplasia, and this intratubular germ cell neoplasia may extend into the seminiferous, the rete testis. Another important thing is adenocarcinomas can arise from rete testis.
Seminiferous tubule, straight tubule, rete testis, and efferent ductules, ductuli efferentis, stain hematoxylin eosin, low magnification. Interstitial cells of Leydig, straight tubules, seminiferous tubules, interstitial connective tissue, seminiferous tubule, straight tubule, and rete testis. Then low magnification rete testis, ductuli efferentis, mediastinum testis, sperm, rete testis with the sperm. Then in high magnification, ductuli efferentis, sperm, cilia, mediastinal testis.
So when you see it in high power, the rete testis is lined by cuboidal cells, whereas the epididymis, the ductuli efferentis, I think it is epididymis, and they are lined by stratified columnar cells, and they will have cilia. Remember, that's why I told them they are similar to fallopian tube, because they will help in the storage and transportation of the sperm into the ejaculatory duct. Remember the germ cells, I told there are various stages. We will be seeing it, and we will see the Leydig cells also.
Figure 18.3, primate testis, spermatogenesis in seminiferous tubules, transverse section, stain HNE, medium magnification. Fibroblast, basement membrane, seminiferous tubule, spermatid, primary spermatocytes, Sertoli cells, again Sertoli cell, spermatid, and spermatids. Then on the right side, blood vessels, interstitial cells of Leydig, and spermatogonia, two types, pale type A and dark type A. Again spermatids, Sertoli cell, interstitial cells of Leydig, primary spermatocytes, spermatids, and fibroblasts.
You all know germ cells are the main regenerating cells, so they can have lot of mitosis. That's why you can see so many mitosis in the germ cells. Okay, see one mitosis, two mitosis, but they are all normal mitosis. Even the non-mitotic germ cells, they will have thread-like chromatin. And see the Leydig cell. Leydig cell are usually pyramidal shaped cells or tall columnar cells. that will have vesicular nuclei with a prominent nucleoli. And their function is the germ cells will be getting all the nutrients from the
Certainly cells.
Sertoli. I told what cell? Leydig cell. So, sorry, ma. Sertoli cell. And in mature spermatocytes, you can see the tail. By seeing the tail, you can tell them they are mature spermatocytes. It's very difficult to differentiate primary spermatogonium, secondary spermatogonium, and other stuff. The applied aspect, sometimes you see only Sertoli cells, no germ cells at all. And that is known as Sertoli cell only syndrome. The whole seminiferous tubule will be lined by cuboidal, tall columnar cells. This is Sertoli cell only syndrome. That you have to remember. Second thing, you may not see that maturation. Germ cells, you see, there are varying sizes and shapes of germ cells. And the mature spermatocytes are inside the luminal surface, and they are all having tail-like pattern. All this maturation may not happen, and that is known as maturation arrest. Testicular biopsy they may do in cases of infertility. They want to know whether the testis is producing the mature spermatocytes or not. In that, some conditions you may see germ cell arrest or maturation arrest, where they may not be coming into mature spermatocytes. And I think there is a scoring system called the Johnson's scoring system. You can see it, and it is used in testicular biopsies done for infertility. The more the mature spermatocytes you see along with the tails, the better the fertility rate. The Leydig cells are they are known as interstitial cells because they are in the interstitium in between the seminiferous tubules. Here you can see much higher power. Again, it is the same thing. Sertoli cells and germ cells of varying stages with the mature spermatids in the spermatocytes in the luminal surface.
Figure 18.6, ductuli efferentes and tubules of the ductus epididymis. Stainless hematoxylin and leucine. On left side, low magnification. On right side, it's a high magnification. On low magnification, we are seeing ductuli efferens, connective tissue, cross section of ductus epididymis, longitudinal section of ductus epididymis, smooth muscle layer, and epithelium. On high magnification, we are seeing sperms, pseudo-stratified columnar epithelium with stereocilia, principal cells, basal cells, smooth muscle layer, and connective tissue.
Yeah, the main thing you have to remember, they have like a respiratory epithelium, they have cilia. You can see it in high power, you can see the cilia very well. So, fallopian tube and epididymis will have ciliated cells. Super. And they help in the storage and the transformation of the spermatozoa. And there is another interesting point you have to remember. When these sperms escape and when they come here, they will produce granulomatous reaction. Why granulomas are produced when the sperms escape outside the epididymis? There are very few structures in our body that are not exposed to our immune system. So, when they are exposed to our immune system, they will produce type 4 hypersensitivity reaction. There are 4 hypersensitivity reaction, 1, 2, 3, 4. Okay, 1, 2, 3 is antibody mediated, whereas 4 is cell mediated. Cell mediated. Whenever you have a cell mediated hypersensitivity reaction, they will produce granulomas. Whenever you see granuloma, you have to see whether it is necrotizing or non-necrotizing, isn't it? Most of the necrotizing is of inflammatory origin and non-necrotizing are of autoimmune origin. The best example you have to remember is tuberculosis in sarcoid. Tuberculosis is the best example of inflammatory necrotizing granulomatous reaction. Sarcoid is best example of autoimmune based non-necrotizing epithelioid granuloma. And the sperm is one. There are 2 more I know. Lens fluid, 1 more, colloid. Okay, in thyroid. That's why when have you remember the palpation thyroiditis, you keep on palpating the enlarge thyroid gland, and they will cause a release of colloid into the extrafollicular space, and they can produce granulomatous reaction, and that we call it palpation thyroiditis. The TB is attacking the genital system. It first goes to epididymis. I don't know the reason. Okay, exactly the reason is not known, but that is known as tuberculous epididymoarchitis. But whenever you see pyuria without growth, you think of tuberculosis. This is the vas. Vas is another structure where there is no submucosa.
A ductus or vas deferens transverse section, stain H&D, low magnification. From the top left, inner longitudinal muscle layer, middle circular muscle layer, outer longitudinal muscle layer, blood vessels, venule and arteriole, adventitia, and then longitudinal mucosal folds, lamina propria, pseudostratified columnar epithelium.
You have to remember this vas deferens, ureter, and the epithelium of the genitourinary system can show atypical cells. When you see atypical cell, what is the other thing you will be looking into? Mitosis. Okay, no mitosis, only atypia. What do you think?
Reactive atypia, sir.
Any other name? Degenerative atypia. There is two things you have to remember. One is ancient schwannoma, other one is symplastic leiomyoma, where the nuclei will be very atypical and they are degenerate. When you see mitosis without atypia, it is regenerative atypia. But when you see atypia and mitosis, it is neoplastic.
Ampulla of the ductus or vas deferens, stain H&D, low magnification. On top left, we have glandular diverticula or crypts, then epithelium, lumen, mucosal folds, adventitia, lamina propria, inner longitudinal muscle layer, middle circular muscle layer, and outer longitudinal muscle layer.